না ঠিকে আছে মই বাইদেউ কৈছোৱেই দাসাৰৰ ফোনটো পোৱা নাই মই ফোন মাৰি আছো পোৱা নাই ফোনটো মেবি ৰাস্তাত থাকিব পাৰে
Okay, fine. Baidu, you
দেৰি
can,
হ'ব পাৰে
apuni start
বাইদেউ ষ্টাৰ্ট
kori.
কৰি দিব
Okay.
ৰোহন
Rohan,
ৰোহন
Rohan,
Ma'am.
Rohan,
তুমি লিংকটো দি
YouTube
দিব
live
পাৰা
is on.
Yes, ma'am.
Okay.
Okay.
so we can start now
Baidu.
yeah
Sachdeva on kori dia.
সজদেৱা ছাৰ আছে নাই ওচৰত
No, he is mute.
Ase.
Now mute hoye ase.
Yeah, I'm okay. I can listen to all of you guys.
Okay, okay.
okay
Good
okay
evening.
thank you
Good evening to all.
We are starting our program.
Yeah, please start. Please start.
Good evening, everyone. Welcome to Naboy Classroom. So I think this is our fourth Naboy Classroom. So today's speaker is Dr. Kesavananda Kaur and Dr. Sasdeva, where I think he knows him very well. So in this classroom, he's going to speak about anatomy and radiological anatomy of nose and paranasal sinuses. We have two learned moderator among us, Dr. Rupanjita Sangma and Dr. Niteshwar Singh. So I welcome you everyone to our academic program. And now I request Dr. Anjan Jyoti to kindly introduce our today's national faculty and expert of this academic session. Over to Anjan.
thank you madam thank you so it's a privilege to introduce Dr. Sanjay Sachdeva sir he is a highly accomplished ENT surgeon with over 37 years of experience in this field. He is a pioneer in advanced ENT procedures and has made remarkable contributions to skull-base surgery, snoring surgeries, cochlear implant, and endoscopic sinus surgeries. Currently, he is the principal director of ENT and head and neck surgery at Max Hospital. He has been holding this position since 2010. Dr. Sachdeva is ENT, MS ENT in 1986. He did his master's from prestigious Maulana Azad Medical College, New Delhi. Uh, about his publications, he is an accomplished author and co-authors in numerous books, namely Endoscopic Sinus Surgery, and a Easy Guide to Ear, Nose and Throat that was published by the National Book Trust of India. India's skull-based surgical approach that is published by L. Vischer in India, and his research has been widely published in national and international journals. He has a lot of certificates, and he conducted a lot of conferences and workshops. He also achieved a cochlear implant certificate of achievement and cochlear implant workshop in Bionic in Bangalore. Dr. Sachdeva is an advisor to the Indian Association of Surgeons for Sleep Apnea, and with his past experience and research contribution, dedication to surgical achievements, Dr. Sachdeva continues to be an inspiration in the field of ENT. It is an honor to have him with us today, and we look forward to gaining insight from his expertise. Please join me welcoming Dr. Sanjay Sachdeva, sir. We welcome you, sir. Your presence will give us a lot of insights into the topic. Thank you, sir.
Thank you so much for very kind words. Thank you, Dr. Anjan. Thank you.
Yeah.
Welcome. We all welcome you.
Now I'm going to introduce our today's speaker, Dr. Kesavananda Kaur, consultant ENT and head and neck and skull-based surgeon, is affiliated with Shukafa Multi-Specialties Hospital at Sibsagar, Assam. He completed his MS in ENT from Guwahati Medical College. Following his post-graduation, he spent 8 years at Fortis and Max Hospital, Delhi. He has extensive experience in ENT, head and neck, and skull-based surgery. He delivered lectures on various topics related to endoscopic sinus surgery in various national conferences. He conducted live neuroendoscopic surgical workshop at Manipal Hospital and Vizag. Additionally, he has organized several instructional courses on temporal bone dissection and cochlear implant surgery. Welcome, Dr. Keshav, to this academic session. Now I am going to introduce our two moderators, Dr. Rupanjita Sangma, who passed her MBBS in 1995 and MS in 2008 from Guwahati Medical College. She has more than 20 publications in national and international journals. She was the editor of Northeast Branch of Association of Otolaryngologists of India Journal from 2019 to 2024. She delivered lectures in various national conferences and national regional conference too. She organized hands-on cadaver dissection and live surgical workshop on FAS at Assam Medical College and Hospital in the year 2022, and temporal bone hand-on cadaver dissection and otology live surgical workshop at Assam Medical College and Hospital in the year 2023. She was the professor and head of the Department of ENT and Head and Neck Surgery at Assam Medical College and recently transferred to Nagaon Medical College. Welcome, Dr. Rupanjita. Our next moderator is Dr. Niteshwar Moirentham Singh. He is ENT consultant at Siza Hospital in Imphal, Manipur. He has a brilliant academic career. He is the first surgeon to perform cochlear implant in Manipur. He performed endoscopic angiofibroma, vestibular schwannoma, and various complex surgeries and successfully. I welcome our speaker, Dr. Keshavananda, and two moderators, Dr. Rupanjita and Niteshwar Singh, to this academic session. And I hope this session will enrich us with a lot of knowledge and will be a fruitful session. Over to moderator to start the program.
Thank you, ma'am. Without wasting much time, I would now ask Dr. Keshavananda to please start his deliberation. Dr. Keshavananda?
Just a second, ma'am.
Yeah, okay.
Good evening, all the esteemed members. And it's an honor to present this presentation in front of my mentor, Dr. Sanjay Sachdeva. So I'll be briefly touching the surgical anatomy of the paranasal sinuses. Mostly, it will be mostly related to the surgical anatomy which we deal with in a routine sinus surgery or which we deal with in routine nasal endoscopies. So to begin with, the paranasal sinuses, this region is one of the most complex areas of the human body and is consequently very difficult to study. The surgical anatomy of nose and paranasal sinuses is published with great detail in most of the standard books. But a thorough knowledge of all the anatomical structures and variations combined with the cadaveric dissections using paranasal blocks is utmost importance to perform proper sinus surgery to avoid any complications. The complications seen with this surgery are very common due to non-familiarity with the anatomical landmarks of the paranasal sinuses during surgical dissection, which is consequently performed beyond the safe limits of the sinus. So, as a sinus surgeon, one must be able to orient himself or herself while looking through optical instruments that provide better illumination and a greater view of the delicate structure of the nose and paranasal sinus. The surgeon must also develop a mental three-dimensional structure, anatomical image, allowing himself or herself to know the precise location of the relationships of the vital structures, especially where the danger points lie. To achieve these goals, it is wise to perform reasonable number of surgical dissections on cadaveric specimens, attend several dissection courses, and participate in regular meetings. So now to begin with, when we do a simple anterior rhinoscopy, mostly we see uh, the simple anatomical structures. What we find is like the in nasal cavity. The internal nasal nose is constituted by two nasal cavities, which extends from the nares to the choanae and is separated by the nasal septum. The nasal cavity is roughly a right angle triangle in outline. It is slightly wider towards its central position. The nares leads into the vestibule, the skin-lined part of the nasal cavity that contains the vibrissae, the hair follicles, and the sebaceous glands. The vestibule is limited above and behind by a curved ridge, the Lyman nasi. The recess of the vestibule reaches upwards into the tip. The junction of the nasal skin and the mucous membrane of the nasal cavity occurs at a variable distance inside the nose, which is visually we can just putting our anterior doing our anterior rhinoscopy, we may see the difference between the junction of the skin and the mucosa. The union of this skin-lined mucosa and nasal vestibule is the chamber of the nasal cavity that has the shape of a triangular aperture. And it is the narrowest part of the normal nasal airway, nasal cavity. So this is the nasal valve area. Its superior lateral limits are formed by the upper lateral cartilage. Its medial wall is represented by the nasal septum and its base and the floor of the nose. The nasal valve area marks the junction between the lower limit of the upper lateral cartilage and the upper portion of the medial and lateral crura of the lower lateral cartilages. The mucosa of the nasal cavity has pseudostratified ciliated columnar epithelium and communicates with the adjoining sinuses and with the nasopharynx via the posterior corona. The nasal cavity is can be divided into the roof, floor, and medial wall and the lateral nasal wall. In the roof segment, the upper zone of the nasal cavity, which is called the olfactory cleft, it is divided into nasal part lying anteriorly, an ethmoid area centrally, and a sphenoid part posteriorly. The sloping anterior portion of the roof of the nasal cavity is formed by the nasal bones and the nasal spine of the frontal bone. The central segment of the roof is mainly defined by the cribriform plate of the ethmoid bone and is referred to as the olfactory area. The descending part of the roof is of the posterior part of the roof of the nasal cavity is constituted by the anterior wall of the sphenoid sinus, the sphenoethmoidal recess which lies in this posterior segment. The junction between the vertical anterior wall and the horizontal floor of the sphenoid sinus marks the end of the nasal cavity and forms the boundary of the choana. The medial wall of the nose, consists of is formed by the septum, which is composed by the cartilaginous and bony segments. The cartilaginous segment consists of the quadrilateral cartilage, which is a contribution from the lower and upper, with a contribution from the lower and upper lateral cartilages. It is the upper margin of the septal cartilage is connected to the posterior border of the posterior border of the intranasal suture and to the upper lateral cartilages. Anteriorly, this cartilage is related to the medial crura of medial crura and sorry, the middle crura of the lower lateral cartilages, and superior level and inferiorly it rests on the anterior nasal spine. This spine is the extension of the maxillary crest. Also, inferiorly, the quadrilateral cartilage sits upon the groove in the maxillary crest. The bony elevation of the floor of the nose on which the entire cartilaginous septum sits is shaped much like a lines of a railroad track. The bony segment of the nasal septum includes the perpendicular plate of the ethmoid bone and the vomer. The perpendicular plate forms the upper and anterior part of the bony septum and continues with the cribriform plate. The vomer is located below and behind the perpendicular plate of the ethmoid bone. The long anterior part of the vomer articulates with the perpendicular plate superiorly and with the quadrilateral cartilage inferiorly. The inferior border of the is related to the nasal crest formed by the maxilla and the palatine bones. These structures of the nasal septum are covered with a mucosal lining, which consists of the mucoperichondrium and the mucoperiosteum. Now, this next comes the most important structure, part of the nasal cavity, that is the lateral nasal wall. It is a anatomically very much complex structure, and the lateral nasal cavity can be divided into three areas. Anteriorly, the lateral nasal wall consists of the frontal process of the maxilla and the lacrimal bone. The middle area is formed by the ethmoid labyrinth, the maxilla, and the inferior turbinate. And the posterior portion of the lateral nasal wall is represented by the perpendicular plate of the palatine bone and medial pterygoid plate of the sphenoid bone. This complex osteology of this lateral nasal wall is represented by the 8 different bones, which are articulated in a very unique way to form a firm bony structure. Most important features of this lateral nasal cavity are the turbinates. These are usually three, and rarely they have a fourth turbinate may be there. The superior, namely the superior, middle, and inferior, is almost present in all individuals, and very rarely a supreme turbinate may also occur. The supreme, superior, and middle turbinates are included in the ethmoid bone, is a part of the ethmoid bone, and the inferior turbinate is an independent bone. The air spaces between these, below these turbinates, are named accordingly the superior, middle, and inferior meatus. They communicate with the common nasal cavity at the lower edge of each meatus. The inferior surfaces of the free hanging portions of the turbinates are almost parallel to the nasal floor, but their supporting attachments usually are oriented diagonally from posterior inferior to anterior superior. Each supporting portion of the each supporting portion of these structures are called as the primary lamella. So basically, what we find in these are the five basic lamellas from anterior to posterior. So the first one is the uncinate process. Second is the lateral extension. Second is the lateral extension of the ethmoid bulla. Third is the basal lamella of the middle turbinate, and fourth is the attachment of the superior turbinate, and fifth lamella is the supreme turbinate if at all present. Otherwise, four lamellas are universally present. So the ethmoid sinus cells are divided into anterior and posterior groups based on their initial sites of pneumatization and the subsequent locations of their ostia. Ethmoid cells may be further characterized on the basis of their skeletal structures where they pneumatize. So it is possible to define these groups in according to within the ethmoid cells and lying cells lying outside the ethmoid groups. So like ethmoid cells that belong to the ethmoid bone include the conchal, bular, infundibular, frontal recess cells. Among those that extend beyond the ethmoid bone are the agar nasi cells, which are the anterior-most ethmoid cells. They pneumatize, which are pneumatization of the frontal process of the maxilla and lacrimal bone. And the frontal sinus cells is the anterior ethmoidal cells that pneumatize the frontal bone. The orbital cells, the anterior ethmoidal cells that pneumatize the orbital roof. And the palatine and sphenoid bone cells, the posterior ethmoid cells, and they pneumatize these bones. So ethmoid sinus is mainly is responsible for the cellular colonization into the surrounding structures. All these different various structures, sinuses we found, these are all the pneumatizations of the ethmoid sinus. So anteriorly the agar nasi, superiorly the frontal sinus, and inferiorly the uncinate process, laterally into the orbital bony structures, and medially to the medial surface, the middle turbinate, they produce to do the middle turbinate, they produce concha bullosa. So because of this haphazard growth, they make smart spinal different from each and every individual have a different ethmoid cells because of this haphazard growth patterns. So the cells which are located within the ethmoid bone can be termed as the intramural cells, and whereas those whose development involves the adjacent bones such as the maxilla, lacrimal, frontal, or sphenoid, they are called as extramural. But regardless of their developments, they can be termed, usually what we term them by the names of their bones in which they reside, like frontal in the frontal sinus, sphenoid and ethmoid, and maxillary. Now coming to the frontal sinus. Frontal sinus is usually is it starts developing by the age of 6. It starts appearing by the age of 6 years. In sometimes so the development of the frontal sinus it develops by the ethmoidal in various ways. It may be a direct extension of the whole frontal recess, or from the laterally placed anterior ethmoidal cells within the frontal recess, or from the ethmoid infundibular cells, or from one or more of the anterior group of ethmoid cells arising in frontal furrows. This great variation in the development of the frontal sinus accounts for the changes found in its drainage systems and for the presence or absence of the true frontonasal duct. The frontal sinus can therefore be a direct extension of the whole frontal recess into the frontal bone, or from the extension of anterior ethmoid cells within the frontal recess, pneumatizing into a frontal sinus. According to the development, there is a change in the formation of the frontonasal duct. So it that it, this usually in whatever way they develop, it doesn't affect the frontal sinus as a whole, but the frontal recess and the ostia of the frontal is the primary frontal sinus ostium. So here in the left picture, we can see this is a complete aplastic frontal sinus with a very smaller pneumatization at the beak only. And here in the second picture, we can see only unilateral pneumatization of the frontal sinus. And at the extreme right, we can see a good sufficient pneumatization of the frontal sinus. So next important structure what we deal with during sinus results, any sinus surgeries, is the middle turbinate. So middle turbinate is unique in its own attachment. And then in the extreme, this diagram, we can see it is the right middle turbinate. You can see the attachment. The middle turbinate is attached in three different ways. Superiorly, it attaches to the skull base directly. It is the superior attachment, which is we can see in this coronal section, and the basal lamella, which is the vertical attachment. It is in the sagittal plane, and finally in the lower picture in the sagittal plane, we can see this the horizontal attachment of the middle turbinate. Next is the sphenoid sinus. Now, the sphenoid sinus can be categorized in terms of its development as in the figure above. The A, it is according to the pneumatization of that, it may be conchal or fetal type with a very slight pneumatization, and its corresponding CT we can see is a very slight pneumatization with the whole of the cellar bone is a complete solid. And second is a pre-cellar or juvenile type, which is a partial pneumatization, and cellar is a complete pneumatization of the sphenoid sinus of the cellar bone. So now here in the sphenoid sinus, in the axial sections, if you see in the section axial sections, the figure A, it is here we can see is this white arrow. It shows the Vidian canal, then the black arrow, the foramen ovale, and the dash one is the foramen spinosum. So these foramina are very much important to understand in the disease pattern, various disease pattern, but particularly not in terms of if you go for a routine sinus surgery, these canals usually we don't encompass. But in terms of if you go for an extensive some tumor surgeries or some skull-based surgeries, these foramina are very much important, and we have to study them. And in each and every section, so the axial and the coronal sections, we have to correspond the things, and then we have to figure out a 3D visualization of the whole image inside your brain when you go for the surgery. So again, this middle turbinate can be of various there can be variations in the attachments and in their formations. Mostly, this is on the left side is the normal middle turbinate, which is the curvature is should be laterally placed. If that is paradoxical, it is a medially placed curvature. or there may be pneumatization of the middle turbinate causing this is the concha opulosa producing, and here we can see radiologically this concha has very much displaced the during the development of the bones only the septum completely towards the right side. Here we can see both sides the concha has there is a pneumatization of the middle turbinate. So middle turbinate, the middle turbinate is the portion of the ethmoid bone that is the 4 centimeter in length approximately. So the interior end of the middle turbinate inserts into the ascending process of the maxilla and the posterior medial edge of the agar nasal. The superior attachment is the paramedian sagittal plane adheres to the lateral edge of the perforated portion of the cribriform plate. And because of the twisting attachment to the middle turbinate, it bends within the middle third to form a basal lamella. So this basal lamella is the limit of the division of the anterior ethmoidal air cells and the posterior ethmoidal air cells. The most so most importantly, what we deal during sinus surgeries is the lateral nasal wall, which consists which what we call is the osteometal complex in the lateral nasal wall. It comprises of the uncinate process, the hiatus semilunaris, the ethmoid bulla, the middle turbinate, and the superior turbinate. This is the maxillary sinus ostia. This area is the focus of our surgery primarily. This constitutes the uh, osteometal unit of the maxillary sinus. Here, the superior turbinate, which belongs to the ethmoid bone, it measures approximately 1 to 1.5 centimeter length. The superior turbinate is is attached to the lamina papyracea of the ethmoid bone. So, the superior turbinate, why it is important, although it may not be that much of a bigger size, but the importance lies in when we enter, it helps in identification of the sphenoid sinus ostia. Usually, when we enter into the sphenoid sinus, we have two identification points to enter into the sphenoid sinus. It's one media when we enter medially through the medially from the middle turbinate. The moment we lateralize the sphenoid sinus of we can see the superior turbinate, we can see the sphenoid ostia. And similarly, on the from when we approach towards from the medially through the basal lamella, we have the moment we clear up the posterior ethmoids, we and on more medially we see the superior turbinate, and removing the superior turbinate, we can encounter the sphenoid ostia. So next, the important is the structure is the uncinate process. The uncinate process is a thin sagittally oriented lamella that runs anterior-superiorly to posterior-inferiorly from the roof of the ethmoid bone to the perpendicular plate of the palatine bone and to the ethmoid process of the inferior turbinate. The 3 to 5 bony spicles unite the inferior convex border with similar structures of the ethmoid process of the inferior turbinate. The posterior and the uncinate process curves laterally upward towards the roof of the maxillary sinus and may be continuous with the perpendicular plate of the palatine bone. It usually covers the infundibulum anteriorly completely. It is like a curtain. The first step in any sinus surgery is to identify the uncinate process and open up the uncinate process. Once you open up the uncinate process, it's very clearly we can see the maxillary ostia and the ethmoid bulla is completely in front of us. Next, in terms of the few anatomical variations, is the Heller cells. Heller cells, which are the cells, which are the cells group of cells which are the nematized from the at the floor of the orbit. The surgical importance of these Heller cells is usually they are absolutely asymptomatic, but there are potential chances that if they get infected, the infection may extend into the orbit very quickly. And because of extensive pneumatization of this area, the osteometal complex may get compromised. So this may cause further obstruction into the maxillary antrum, leading to uh, further disease in this maxillary sinus. So while reading the CT scan, this cell has to be kept in mind, and because the moment we open up the uncinate process, but we don't address to this cell, so this part of the surgery remains ineffective. Next one important cell is the Onodi cell. It is the sphenoethmoidal layer cell. It is the posterior-most ethmoidal layer cell that extends posteriorly to above the superior the sphenoid sinus and is very close proximity to the optic nerve and internal carotid artery. Usually, these cells, this is happen because of the hypernematization over there. These are completely asymptomatic cells, but when they are susceptible to disease, these area poses a much risk while for getting the injury to the optic nerve or the internal carotid artery. So, to summarize, gradually I will complete my presentation with two further classifications which we need to keep in mind is the Delano classification of the optic nerve. It is classified into four types. The type one, where the optic nerve is completely within the sphenoid bone, which on exposure in the sphenoid bone, we usually don't get any indentation. In type 2, there is a slight indentation. And in type 3, there is 50%, more than 50%, approximately 50% of the optic nerve encasement. And in type 4, it's completely, the optic nerve completely lies within the sphenoid sinus cavity. So in these cases, there are very high chances of the optic nerve damage during surgeries. One more important classification is the Quiros classification. It is the classification of the olfactory group area, which is the type 1 is 1 to 3 millimeter in depth from the lateral lamella from the cristae galli, and type 2 is 4 to 7 millimeter, and type 3 8 to 16. The lower this cribriform plate, that there are higher chances of getting injury over there, leading to CSF leak. So prior to address this area, we need to have a proper in cases of an extensive sinus diseases. There are very high chances of injury into this area. So even though if we don't find, say, there is extensive disease in this area in a type 3 type of cribriform area, we may need not to remove each and every disease over there. If the ventilation is well, we can leave some of the tissues over there because that can be taken care of with medications in terms of because by that way we can avoid injury to the area, olfactory area. Uh, and thank you. That will be all for very briefly. I have summarized. I mean, I have not gone into very deep into the. Thank you.
Thank you, Dr. Keshavananda, for that elaborate and excellent deliberation. I would now request Dr. Sachdeva sir to please share his expert comments.
So I think that is a wonderful presentation, Dr. Keshav. Congratulations, and congratulations to all of you
Thank you, sir.
who have started this education program. Kudos. And so if you just, I don't think I can add anything more. He's been so elaborate and so explicit in his description. 2-3 things which you have to remember is that, like he said, the skull base is very, very intricate, and the variations are so much, and we have to keep learning and learning. I remember I did a workshop in Brunei, and the patients that we saw there, they all had 5 turbinates, irrespective. And there were few who also had sixth one. The skull base was very slanting, so it comes up high initially when you start your surgery, and then slopes down radically and comes down on you and the sphenoid. So only way you can actually save yourself for getting into these kind of complications is to study the CT scan yourself. So you need to have CT scan in all the 3 dimensions: coronal, sagittal, and axial, and have cuts which are very fine, so that you can delineate differentiation between the soft tissue and the bony landmarks, and keep the landmarks in your mind, in front of you, and as a roadmap for your surgical intervention. So that is one thing. And second thing is, nose has now become a corridor to enter the skull base. Pituitary is just AB or A of AB, A to Z alphabets. So we have to go beyond. So if you do our dissection courses, then we can show you from first cranial nerve to 12th cranial nerve through this nasal corridor. So it's all possible. If we can learn and master that, then I'm sure we can be a good skull base surgeon, and we can see so many of us getting into that kind of an area with great expertise. Thank you so much, and congratulations again to Dr. Keshav.
Thank you, sir. Thank you.
Thank you, sir.
Thank you so much, sir, and heartiest congratulations to Dr. Keshav. And now, to carry on the discussion, if may I invite any queries there, if anything needs to be answered, or if there's any
Two
questions.
queries have been put by Fukan sir.
Mhm.
One was missed out because of a shortage of time, Keshav. Kuhn's classification was not mentioned.
Oh, yeah.
So that is one of the questions, I think, by Fukan sir.
Kuhn's classification is a classification of the frontal cells. There are 4 types of frontal cells. It is this type 1 is a single cell above the agarnes eye. Type 2, a few group of cells. Or type 3 is a single large cell above the agarnes eye, which extends through the frontal ostium into the frontal sinus. And type 4 is a completely isolated cell entirely within the frontal cell, which is not connected to the frontal recess.
Yes.
Within a cell.
Okay. Thank you. Another question again by Fukan sir is surgical importance of 3-cellular pneumatization.
Cellular pneumatization, the surgical importance mainly lies in terms of when usually in routine sinus surgeries, if there is a very osteometal unit disease, we usually don't address deeper into the sphenoid sinus, but we are morely restricted with the sphenoid sinus ostia, opening up this ostia. But if we have extensive sinus diseases posteriorly in the sphenoid sinus, or if we are dealing with, say, skull-based surgery, as Dr. Sadeva says, the pituitary surgery or any cellular surgeries. So at that portion of the time, we need to have these classifications, this type of pneumatization are very much important, because if it is very much pneumatized, it is very easier for us to address the cellular area. But if it is very much less pneumatized, a kind of a fetal type of cell, which a very small cell, so the bone which we have to drill, it's way deep. It's a very thick bone we have to drill out, and because of that thicker bone, there are high chances of injury to the vital structures over there. The carotid is there, optic is there, so we may injure at any time. So in such cases, the importance comes there.
And it's good to have navigational in such cases to be used. Otherwise, in normal sphenoid sinus pneumatization, we usually, of course, it's required in skull-based cases, but then we can do it without the navigation system also.
Yeah.
Just to add, the Keshav, you mentioned about two approaches to the sphenoid sinus.
Yeah.
Since we were discussing about the sphenoid sinus,
Mhm.
so the two approaches you were mentioning about, one is medial approach and one is lateral approach.
Yeah.
The medial approach is through the sphenoid recess, and the lateral approach is through the posterior ethmoid.
Great points.
Yes, I would like to. It's just a simple, small thing. I would like to add, there is another approach called intermediate approach, where in this intermediate approach, what is done is, once you do the anterior ethmoidectomy, you go up to the what's it, ground lamella. Once this ground lamella is perforated, you go straight to the posterior ethmoid, because that's the defining place between the anterior ethmoid and the posterior ethmoid. Now, once you enter the posterior ethmoid, you make an opening in the middle turbinate. The moment you enter the middle, or you made the opening in the middle turbinate, we are automatically into the superior turbinate, where you see the superior, superior meatus, where you see the tip of the superior turbinate. So if we dissect that tip of the superior turbinate, or the inferior one third of the superior turbinate, we go directly in front of the sphenoid os.
Yeah.
And two advantage, what I felt in this one is, first, you don't get lost, because the superior turbinate always guides you towards the sphenoid os, because the sphenoid os is always medial to the superior turbinate, the attachment. Another thing is, you avoid going above towards the skull base, because the superior turbinate is hanging from the skull base. So that way you avoid it. The third thing is, once you enter that area, we are always entering in the medial portion of the sphenoid sinus, which is devoid of many important structures, except for that inferior part of the sphenoid opening, where the your posterior
As a
septal branch
supplementary.
of the sphenopalatine artery goes. So that I feel is a very good approach, and this is what I usually do, and yeah, it's very safe actually, and because when regarding ONOD, whether it's an ONOD or whether it's a sclerotic, you go to the sphenoid os only. So even if there is ONOD, you have a least chance of injuring to the carotid, because you are not going lateral. You have a least chance of injuring to the optic, because you are not going above. So and you have a least chance of CSF leaks, because again we are not going above, because our direction is directed by the superior third. So this is one point that I wanted to add.
But that in case is in terms of ONOD cells, but true in terms if we are going too much into the sphenoid sinus. If there is a disease sphenoid sinus, it's a simple. There is but we need to establish a ventilation only. So then we
Yes,
may
better
not
not
need to
to
go
go too deep.
because we will not
Yes,
be opening up sphenoid that much wide.
true. And
The
regarding this, just one word regarding this ONOD cells for the juniors, of course. You should be careful when you read the CT scans. You should just locate if there is an ONOD cell, because if there is one, then the bulge of the carotid you may not be able to visualize in the sphenoid. So don't go for searching for that bulge. Otherwise, there's every chance that you'll, damage that sphenoid sinus and enter into the noddy cell and damage the carotid bulge.
yeah,
So that
madam, if
is
I
one question.
yeah,
So
if in doubt,
with your permission, can I add a few things here?
please sir,
Please,
please
sir.
sir.
Sure, sir.
So that's really very interesting. Saying about the image guiding and all those kind of things, they're absolutely, I think, should be a part of our operating room furniture. But when we started doing our pituitary in 92, 93, we did not have an image guided system. So we started using C arms. So people who still don't have image guided, don't think that you can't do skull based surgery. You still have a C arm, and C arm guides you quite well. And you are quite safe in terms where you have a conchal sinus, a sphenoid sinus, or aberrations, and especially in revision surgeries. So revision surgeries is a catch where you have to be really really careful. And the approach to sphenoid sinus, very interestingly, three approaches have been mentioned, and one aspect has to be considered quite seriously, is that one element of nasal cavity will never ever be injured in any surgery. That's the choana. So
Exactly.
superior choanal margin will be a very safe bet to go 15 millimeters. So all you need to do is you have a 4 scope, you add 4 4 4 through three scopes ahead, you will find the ostia of the sphenoid sinus. So we have to remember that the ostia of the sphenoid sinus would be at the highest point of the sphenoid, and above that would be the planum sphenoidale. Never ever go beyond posterior ethmoid looking for the sphenoid, because posterior ethmoid roof is much higher than the sphenoid sinus. So sphenoid sinus is always one story below the posterior ethmoid. These are few pointers which you can actually pick up during dissection, what Dr. Keshav has already mentioned. So we do a lot of dissection courses. I think he's also doing them. And so please attend more and more dissection courses to get onto these variations. Correlate the CT scan, keep the CT scans right in front of you at every point in time to make CT your surgery safe. But having fancy gadgets would not ensure safety. Safety is always by knowing your anatomy in and out. Thank you so much.
Thank
Certainly.
you, sir. And I think, sir, for beginners, the medial approach would be the best to start with.
Yes,
Yes, but it's the narrowest again. It's safest but narrowest.
but as Dr. Sachdeva has said, that because I forgot to mention what he have told, because this was the basic thing which I have learned from him, that in case of extensive sinonasal polyposis, you don't get to separate the polyps from the middle turbinate. Sometimes the middle turbinate is so flimsy, you cannot identify it. So the only identification point is, the as sir has said, is the choana. So always remove the polyps along the inferior turbinate, visualize the choana, and then you can come from behind. Because that is, once you have reached the choana, you know your posterior limit, that you don't have to go beyond that.
And to add one, I remember Dr. Sethi sir, who works in Singapore. He says approximately 80% of Asian Mongoloid origin will have conodicils. Approximately 80%. So it's quite high in our regions, you know. So again, sphenoid is again very very important in terms of anatomical this one. And sir, coming to frontal sinus, um, if we have to go to the frontal sinus, and if somebody has to deal with the frontal sinus, what are the most, you know, anatomically challenging that you found is regarding frontal sinus actually?
Means I didn't get you.
I mean, in frontal sinus, is there any some specific anatomical deformity which you have to tackle and which you find it much difficult to do it? I mean, when you are doing frontal sinus surgery, I mean, regarding anatomical things, it's
And
Yeah,
definitely
so frontal sinus is probably, I feel, in my opinion, is the most difficult sinus, and especially if it is a revision case, you have to be very very careful. So there are a lot of landmarks that you can actually use when you're approaching frontal sinus. But thorough CT scan knowledge, study of the frontal area, the frontal outflow tract area, and all the cells which Dr. Keshav already mentioned about the cone, which type of cone cells, how are they oriented, where are they going, where are the lamellae, is related to the uncinate process. If the uncinate process is still there and it's not a revision case, it may not be there. And how the middle turbinate is oriented to that outflow tract will always help you in locating the frontal sinus. But still, it's a challenge. And there are times when you will be lost. You may not be able to figure out. You will maybe need help of image guided. And nowadays, of course, you have these balloons and catheters and light sources which can actually be used as a guide to go in. But if you still can't find the frontal sinus, do not try to explore, because you can accidentally get into the skull base and have CSF rhinorrhea. So it may not be a bad idea to do a small refining in the just below the eyebrow. Make a small opening, maybe 5 millimeter, pass an endoscope and pass some betadine and see where the betadine is actually coming out from in the frontal sinus. But if it is a naive or not a pre-surgical patient, then you will find the frontal sinus medial to the uncinate process where it gets attached. So uncinate, we all know, get attached to three different planes. It can get attached to the lamina praepatia, it can go still straight up to the skull base, or it can have attachment to the middle turbinate, or it can have attachment to any of these three in combination. So once you have the CT scan and you've studied it thoroughly, you will know how the uncinate plate is placed, and then you will be able to figure out where the frontal sinus is opening. If you have cells there, then it will be safer to open up the Hager nasi and then do the eggshelling as classically been taught. Just behind the eggshell, you will find the frontal sinus. Go to more towards the orbit and not towards the cribriform plate, because if you're going a little behind, then you will have. We all know that the fovea ethmodalis is higher than the cribriform plate, so you can accidentally injure the skull base there. So pointers, there will be a lot of pointers, and one important pointer also is that if you're using a 70-degree scope and you place that 70-degree scope in the inferior portion of the maxillary sinus os and look up, you at 12 o'clock position, you will find the frontal sinus. So try it, you will invariably find it in Indian population, but don't try it in any other population, because like sir says that you will have different skull bases, different orientation, and you can sometimes go wrong there. So these are few observations that I just wanted to add on. Thank you, Keshav.
Thank you. Thank you.
Sir,
Thank you,
thank
sir.
you so much. Lovely, sir.
There's one more question from Mukherjee, sir. The importance of attachment of uncinate decides type of frontal sinus drainage.
Sir has already described this.
That has already been, yes. Okay, and that was a nice tip actually given by sir regarding localization of the frontal sinus.
Personally, madam, I feel one of the most important knowledge, anatomical knowledge, when we are dealing with frontal sinus is identification of the frontobular cells. The frontobular
Yeah.
cells. Because if there is a frontobular cell, then we cannot do frontal sinus opening as conventional as we think. It has to be a little different, because that lies in the posterior part. Above that anterior face, the anterior ethmoid or bulla.
If you have the
So,
frontal cells, you mean?
yeah, in frontobular, because that's in the posterior part, and the normal frontal cone cells in the anterior part. So anterior part we can just remove it with a curette. Nothing happens, because anterior there is nothing. But it's the posterior part that is most important. So identifying the frontobular cell again is very, very important, because it can be easily get confused with the anterior ethmoidal, of course, part of the anterior ethmoid, but then anterior ethmoid, the main anterior ethmoidal cells, and usual way of dissecting anteriorly won't work, because for that we have to dissect posteriorly. So again, yes, frontobular is very, very important.
Yes, so that I think should answer Dr. Anjan's query, which was what is the easiest and safest way to enter frontal sinus type 3? Yes.
Sir has
Yes.
already answered that.
Yes,
Yes.
that is good. Importance of interbular. Another question. By Mukherjee, sir. Another question. Importance of intact bulla technique during frontal sinus surgery. So I think we've discussed that intact bulla. You've already mentioned in your slides.
Yeah, it is because the intact bulla usually, uh, for me, I usually don't do intact bulla. I always address frontal sinus and maxillary sinus at the end of the surgery. I
Yes.
cleaned up the anterior ethmoids
Because
and
your view is much
Ah,
better than.
yeah, regarding this one, intake bulla technique, actually the technique arises the from the modification of trying to preserve or trying to avoid injuries to the anterior metal artery. So in anterior bulla, the usual the idea is your bulla, the front face of the bulla always protects the anterior metal artery. And since that anterior metal artery is not only about arterial bleed or artery retracting into the orbital, but also it is the thinnest part of the anterior skull base. So any amount of movement which can cause an injury to the artery can also easily cause a CSF leak. So the bulla, if we keep it intact, the anterior ethmoid is automatically preserved behind it. So if you do an intact bulla technique, the fear of injuring the anterior ethmoid is gone. I mean, it's not there. So I do intact bulla.
I totally agree with you. I agree
Sorry, sir.
also.
So
Like,
I do intake bulla technique almost all of the time, but then in cases where it is very difficult, what I do is I do intake bulla, but then the up to the first foveal cells I open up my frontal sinus opening up to the limits both anteriorly and posteriorly, and then do the anterior ethmoid and then see the identify the anterior ethmoid artery and then proceed it anteriorly to the anterior ethmoid to complete my frontal opening area. So again, yes, intake bulla technique is a wonderful technique.
Okay. So we have another question by Fukun sir regarding orbital cell.
Ramesh told that.
Yeah. I think this has been already mentioned, Dr.
Pillar
K.
cell has been told.
Okay. Then another one. What is the post? This is by Abhinava Ghosh. What is the posterior limit to which an MMA should be done so as to avoid any complications? I think posteriorly, you should not go much posteriorly, too much, to avoid injury. Right, Dr. Keshav?
we can, because there is one lateral branch of the this is the
It should be adequate. That is what is the dictum. I think
this should be adequate, but
adequate but not too big. Anteriorly,
big.
of course, you should not come anteriorly because it will injure the nasal lacrimal.
So the dictum, sorry, if I can just so the dictum is to basically open the natural ostia of the maxillary sinus. So we are we have to be very careful that we don't miss that. And sometimes with 0 degree, sometimes even with 30 degree, you may miss it in few skulls. So it may not be a bad idea to use 70 degree to make sure that you've actually opened the natural ostia. So the natural ostia, as you realize, is a very small ostia, is not a big ostia. So making the opening 4 times or 3 times bigger than the natural ostia, considering that there will be some fibrosis occurring post-operatively and there will be a little closure, still you will have an effective sinus opening where natural opening is open maybe 3 to 4 times middle maxilla, you will have air currents going directly and hitting the posterior wall of the maxillary sinus. And especially people who are using two-wheelers without a helmet, they will feel some pain and discomfort. So we find those things happening practically to our patients if we have opened up too wide. So this is very important to keep it to the natural ostia and close to the natural ostia, maybe 4 times bigger. That's all.
Sir, if I may add, it also depends on the disease for which we are operating actually.
Yeah, I agree with you 100%. I agree with you 100%. So when you are actually doing fungal mucormycosis, we know that the mucormycosis always starts from the sphenopalatine, pterygopalatine area. And those situations you will, But we were basically talking of chronic rhinosinusitis, the standard disease that we do sinus surgery for. For that, whatever I was saying was valid. But for like different diseases where things are different, which may not be a routine kind of a situation, yes, I agree with you 100%. Then you will have to do, you will have to tailor make your treatment plan.
Sir. Lovely, sir.
Okay, I think there are no more anything else, Niteshwar, you would like to put in?
Madam, regarding sir has put the type of optic nerve Delana's classification. So if somebody is, of course, let's classify into two groups where you want to avoid injury to the optic nerve in normal sinus surgery cases, and there is something where you want to actually address the optic nerve by doing decompression and all. In case of traumatic optic neuropathy and all, so in such cases, out of those classification, which one sir would prefer? The type of the type of optic nerve appearance in the sphenoid.
Means prefer means.
No, I mean, that's a very good question. I think that's a very valid
What?
question. First of all, it's important to realize that you are closer to optic nerve in posterior ethmoids than in sphenoid sinus. And when you're doing an optic nerve decompression for whatever reasons you're doing it for, where the indication is required, then you don't start at the optic canal level. You always start at the lamina papyracea level. Start decompressing the orbit at that level, then go on to the ligament of Zen level, and then start doing the drilling. But before that, before you start doing the drilling, you have to first see the periorbita right at the beginning. That would be at the lamina papyracea. That would be a better landmark rather than going straight to the sphenoid sinus, because here you will have the floor of the orbit or the roof of the maxillary sinus right in front of you, the posterior wall of the maxillary sinus. That may be one indication where you will do a large MMA to see the posterior wall of the maxillary sinus, see where the sphenopalatine artery is coming on, and then follow that orbit cone to the ligament of Zinn, start drilling, and then you will, whatever Delano it is, it has to be drilled. So whether it is 1, 2, 3, 4, it doesn't make a difference. The more sclerotic one, you will have to obviously do more drilling. The one which is open or has a 360-degree turn of a very thin bone, that will be easier, but you will have to be more careful not to avulse even a single fiber of optic nerve. So it is a double-edged sword, but you have to be careful anyways. So that is how I would probably take it.
Thank you so much, sir. Yeah, please.
One last question, I suppose. This is from Dr. Sangeeta. In case of floppy middle turbinate during surgery, do we just leave it like that?
It depends actually. If we say
Better
floppy,
not to
means
leave, I think. What do you say? We should, if it's floppy.
it floppy means by the term for floppy, if I say if it's like we can do moisturization or we can take the part of the turbinate. But the moment you
Yes.
put up a suction inside and if it starts fluttering, so then there is no
Hmm.
point doing a moisturization, because with the normal normal breathing pattern, this will again lateralize.
Hmm.
Yeah, excellent, Kashav. That's really good. See, if you leave a floppy middle turbinate, then what we find is with air currents, the normal air currents, it starts lateralizing automatically. And since you've created a raw area in the lateral wall of the sinuses, probably find these synecdoche build up later, and the whole thing narrowing and completely obliterating the openings that you've created for frontal outflow tract and maxillary outflow tract. So it's counterproductive. So moisturization is a good technique which Dr. Keshav has mentioned. And if you feel that may not work and the floppiness is too much, then you can actually do a wedge resection, which will also work very well.
Yeah.
But
Yes.
moisturization would keep the middle turbinate and its mucosa and its endings, because every bit of mucosa and nerve endings of the nasal cavity has to be respected. We just can't chop off everything and then say that everything is going to be all right, because whatever we do will always be falling back on our face in terms of whenever the scarring or synaptic formation are occurring. But excellent, what you said, Dr. Keshav.
Thank you, sir. Thank you.
I think what time is okay. Time is up. I think
One
Dr.
last question is there.
Okay.
Yes, one more question. Last, I think.
Last question.
By
Okay.
Corina Rabha. Bilateral concha bullosa plus bilateral inferior turbinate if it's huge with enlarged adenoids, we address all or leave one?
What I actually feel like it depends upon absolutely what kind of the presentation the patient is giving us. You know,
Right.
in normal population, we also get concabulosa a lot,
Yeah.
but they are
Hmm.
absolutely doing well. You know,
Hmm. If it's
because
not obstructing,
and
yes.
even enlarged adenoids also. What actually is the pathology or for which the patient has come? That completely depends upon that only. That what we have to address.
And she's also asking about bilateral inferior turbinate.
That's what I'm saying. It's absolutely the presentation that will let us know,
I think
because
also.
these are all. It's, you know, in normal patients also you may find in a routine CT there is huge middle inferior turbinates, but the patient is not going to complain you a single bit of that there is any nasal blockage or nothing.
The dictum I follow is, if it's in a child with a what's say, a blocked nose or an obstructive sleep, I would go for adenoidectomy first, and if especially if the concha is not huge, because with adenoidectomy, your sinusitis again subsides. So it's a dual benefit for all of
Okay, she asks, Dr.
don't
Ordina
touch
asks, if
the
it's absolute nasal blockage in an adult. So adenoids, I think that won't come into the picture if the patient is an adult.
Yeah,
Right?
if it's adult, adenoid is not an issue. Yeah.
We can keep
Hmm.
the adenoid there, but we can address the the concabulosa, bilateral concabulosa, and we can do partial resection if at all necessary. Depends upon what kind of septum is there as well, what kind of aeration, how much you get after removing the if you do a medial removal of the sorry, lateral plate of the concha has been removed, and we get much improved airway over there. We can keep respect the mucosa, because inferior turbinate mucosa is the most it is the most important one which we need to keep.
Sir,
What do you think, Keshav? Because in adult also we see some adenoid cases. Means the gouty adenoid also is seen in adult, and
Yes,
in that case, I think all three hypertrophic turbinate adenoid hypertrophy with concabulosa, maybe because of the patient is coming because of obstructive symptoms.
no,
So
in that case
is not it necessary to address everything at the same sitting? We can do that also.
we can do that. We can do
Yeah,
that. That's what I'm
that
saying.
is also possible.
It's absolutely on in terms of the presentation, and it depends
Yeah.
upon the judgment of and the experience of the surgeon, that what he can achieve after the what to do. It's not like that everything over there is obstructed and then we can just clean it out.
yes. Three methods of the dealing with the adenoid sorry, inferior turbinate hypertrophy. One is waist resection or partial resection. Second is out fracturing towards the lateral side, and the third is our Wormel's technique of turbinate reduction. Those three are usually that I do. Others are access.
So our time is over.
Yeah.
So we want to conclude our session. Before concluding, I would like to thank Dr. Sanjay Sachdeva sir for your valuable inputs and sparing your valuable time with us. And we actually supposed to have you in our last NEBOICon, but we couldn't communicate you properly. But thank you for coming to our NEBOIC classroom. And secondly, I would like to thank Dr. Keshavananda for your wonderful presentation. And also, I would like to thank Professor Pranjita and Dr. Nitesha for your moderation and making the session very interactive. And finally, I would like to thank all the participants who are present here to make this academic very interactive and fruitful. I hope in coming sessions also will join in our academic forum. And one participation certificate is available in your in this chat room. Yeah, especially for PGT, you can download it. Uh, who are there in this forum. Thank you, everyone. We can conclude this session here.